this is about where we left off. So we were kind of finishing up with mania. We were talking about some of the speech patterns and the pressured speech and tangential. Their thoughts are all over the place, flight of ideas, they rhyme. So sometimes their communication is really quite difficult to understand. And they might be grandiose or have persecutory delusions. Do you remember any of the examples we talked about? Or does anybody have an example like from previous clinical or some other setting where you've seen somebody with mania? I thought, well, Andrea's not here. I thought she gave an example last week of somebody who had very grandiose ideas and believed different things about themselves that weren't real. You guys kind of remember that? Anyone else have any? Well, when you get to clinical, you will. Maybe you don't have any examples now, but when you get to clinical, you will, because we've actually been seeing quite a few people with mania. For some reason, the springtime, this is kind of almost the start of spring. I'm at least wanting to believe it is, because I heard some birds singing yesterday, and it felt a little warm with the sun out, so I was thinking, oh, it's kind of like spring. But anyways, as spring is approaching, we do seem to see more people with mania. And actually, it's another time of year where we see a lot more people that have suicidal ideation and make suicide attempts. And you think, well, why in the spring? You know, it's such a nice, right? It's such a nice time of year in the spring. It starts to get light again, and we get hopeful. Things start to get green. But then if you think about that, you're right, Sandeep. You're thinking maybe it should be in the winter when things are more dark and cold, and it's dark for so long. And yes, you can get more seasonal depression during the winter, but it seems like for suicide, it's like spring is a time of like growth and rebirth, and everyone around you is getting more happy and hopeful. And if you're depressed, then that makes you even feel worse. And so that's a high time of year for people to be committing suicide. So if somebody gets proper treatment, what types of problems can they avoid? If they're, we get them proper treatment so that they get out of that full-blown mania, or maybe avoid going into that full-blown mania. So we talked last week a little bit about the mania. I showed you that little video clip too, remember? The woman who was swearing a lot, and she had a black eye, and her house was in complete disarray, and her thoughts were all over the place. And so what types of problems can be avoided if your manic person gets proper treatment? Yeah, suicide attempts too, because they're very likely to commit suicide. Absolutely. Very high risk for suicide. What else? Yes, so some unwanted behaviors that have difficult consequences. So shopping sprees. Did I tell you about the person who memorized their credit card number and then made a bunch of purchases from 1K? Did I tell you guys about that? Okay. It must be, when I record my lectures for my online class, I've already done these lectures, so I'm thinking, well, did I tell these guys or did I record it? I must have recorded it. But anyways, so this woman had her credit card memorized, and so from the hospital, she called and she ordered a new refrigerator, a microwave, a washer and dryer. Okay, we're talking like big appliances, like lots of money. She joined a Book of the Month club and then like bought 10 pairs of shoes for herself and like 10 pairs of shoes for her husband. So we're talking like thousands of dollars. Okay, so as soon as, and this is when she's in the hospital. So she must have had her credit card memorized because we don't allow people to have their credit cards. And so she made these purchases. So as soon as they started arriving at their home, her husband quick had to call the hospital and have her phone privileges taken away because she was making all these purchases, at least temporarily, until she was better. And that is something that we have a right to do if somebody is engaging in behavior that's harmful. They didn't have that kind of money to be spending thousands of dollars. So then the husband was able to get those things returned, thank goodness. So that's one example. Somebody else actually bought I think it was like a $40,000 truck that they couldn't afford, when they were when they were manic, and then they wanted the doctor to write an excuse. It was just kind of funny. We chuckled about this one, but they wanted a doctor to write an excuse, like saying they didn't have to pay it back. They didn't have to pay off the loan for that because they bought it when they were manic. It's like, no, that's not going to work, but nice try. But anyways, but people, yes, sometimes they can get into debt. If they have sexual indiscretions, they're going to get STDs, they might get pregnant. What's that going to do to their relationships if they're, out seeing other people? So when they're manic, they just have so many different problems that affect their life, their relationships, all of that type of thing. So, and suicide for sure would be the number one thing that we're going to be thinking about. So we always have to do a self-assessment because people with mania can be very difficult to work with. They're going to push all your buttons. They're going to be testing the limits. They're going to want special privileges. And many times if they really think that they're special or believe they have special powers, they really think that they should be having privileges that other people can't. So they can be very demanding. They want you to do something right now. Stop what you're doing, meet my need. And it's funny sometimes when people that have mania have a student, it's kind of nice because they have you all to themselves. They don't have to split you with 6 other patients. And there are times when somebody with mania, I've seen, they'll just run the student ragged. They'll just ask them constantly, and they won't, group their requests all into, one request. They won't say, oh, I'd like a cup of coffee and a snack from the kitchen and this, whatever, and a PRN. They won't group it all together. They'll say, I want a snack. So student, run, go get the snack. I want a PRN. Run, go get the PRN. You know what I mean? So they kind of can run you ragged. And finally, a student came to me once and said, do I have to do everything that this person wants me to do? It's like, right away, especially, I said, no, you really don't. You can limit set. You can say, you can approach me every half hour, or actually what they do on the unit a lot is every hour. You can make a request every hour. And then write down, if you want a list, write it down so you remember everything, because they're so scattered sometimes. I don't think they're doing it purposely to run us ragged, but I do think they may not be able to keep track of everything, and so it's like an impulse and they ask for something. So write it down, trying to sort of structure them a little bit, and then every hour you can ask for some needs to be met, a snack, a PRN, or whatever. Well, PRNs, I guess we wouldn't necessarily put in that category, because truly if somebody needed a PRN for something, we're not going to make them wait on purpose. But so they can be very demanding. They can do some staff splitting too, pitting one person against the other, and just making it kind of difficult. So staff members have to have staff meetings. Everybody talk about their different approaches to behavior. Many times what they've been doing is they will post a list of expectations for the patient in the nurse's station, so everybody follows it. They used to call it a behavior plan, so that probably sounds maybe a little more demeaning or a little more like punishment. They're calling it a wellness plan now. So if when we get to the hospital you hear somebody's on a wellness plan, that's what it is. And usually it includes things like we expect people to take care of their ADLs. They need to be showering. They need to go to groups. If they're invited to groups, they need to ask once an hour, ask their nurse for something. They can't swear. We just try to set limits. They can't swear at staff, and we expect appropriate behavior and appropriate communication. So it's now called a wellness plan. So that does help. It gives the patient some structure that they kind of desperately need. So we all need to set limits consistently, because if one person gives a privilege and then the other person doesn't, then you really get set up for the patient to be very angry too, and they may even get combative if they perceive certain people as maybe they're punishing them and they're not letting them get their needs met. So we really need to assess if they're a danger to themselves or others. We have to protect them from those uninhibited behaviors. The need for hospitalization, again, is usually they have to be a danger to themselves or others. We always want to look at their medical status, because if they haven't been sleeping, then they might be having some medical difficulties because of that. Sleeping, eating, drinking fluids appropriately. So do you know how long would it take for somebody to die from lack of sleep? if you want, you can use your phones and just kind of look it up. And I'm not sure if there's always a hard and fast rule, but you actually will die faster from lack of sleep than you will from lack of eating. See if you can find it. Very good. Okay, I was going to say probably somewhere around the 2-week period or so. So we do have to take that seriously. And what body system do you think would most be affected by lack of sleep? Well, you had an answer? What did you think? Neurological? Well, no, I think there's another one that's... I think there's another one that's more apt to be affected. It's kind of important. Cardiac, did you say? Yes. Yes, definitely. Your cardiac system is most likely to be affected by lack of sleep. All right, and this is not CHA, so we're not going to get into all of the physiology of why that happens, but that is the correct answer. Okay, we always have to look for coexisting medical conditions and certainly the family's understanding. So need for hospitalization, that's kind of an interesting topic because there are some times when people with mania actually end up in the legal system versus coming to the hospital. A good example, I don't know if you remember this was a few years ago, but I believe it was in either somewhere in Sheboygan County. It might have been Plymouth, I don't remember exactly where it was now. But a woman it sounded to me, when I read the description in the paper, I knew right away this person was clearly manic. She was singing Christmas carols. She was out in the street wearing just like a nightgown. The police were called. Well, she actually bit her husband's tongue. That was the thing that was... Do you kind of remember hearing about that?
That story out there.
Oh, I did already. Okay.
Nothing else, I don't remember.
Okay, but in this context, it's okay. So you remember that story? She threw a cup of coffee at the police officer. She was clearly manic. She ended up in the legal system. So truly, she needed hospitalization. She was clearly manic, and actually, come to find out, I know a friend of hers who says that yes, this woman is indeed very manic, and when she doesn't take her medication, she can really have some very difficult behaviors. So the need for hospitalization, even if somebody is hypomanic, sometimes they need to come into the hospital to avoid perhaps going into a full-blown manic episode. And it is sad to me when people end up in the legal system. Like, why would you bring somebody like that to jail who is clearly ill? So families understanding, police officers understanding, they're not medical professionals. I totally understand that. But I think we need to increase understanding about what types of behaviors they have. So some diagnoses, of course, risk for injury, risk for violence, either other or self-directed, and certainly ineffective coping. So many times they're using drugs and alcohol to self-medicate. So that seems to be okay. The outcomes, I think we can kind of skip over some of these that are just self-explanatory. So, of course, seclusion, restraint, or ECT may be considered during the acute phase. ECT, well, that's electroconvulsive therapy, and usually we use that for depression. So, but occasionally they've used it to bring somebody out of a manic episode, but quite honestly, I've seen it kind of do the opposite. My experience is I've actually seen people go from being severely depressed and having one ECT treatment and going into full-blown mania, like instantly, like within hours of coming out of, the anesthesia for ECT. So I'm not always sure. I know they do use it sometimes, but anyways. But people might need to have restraints during that phase if they're an acute danger to themselves or others. Did I tell you the story about the person who kicked down the seclusion room door with 2 kicks of his bare feet? I tell you about that one? Okay, That was really a big, strong man, and he was full-blown manic. He was locked in a seclusion room. I was doing rounds, and that time we didn't one-to-one people in seclusion. I opened up, there's a little curtain covering the little window, and mostly because then they can't see out and get overstimulated. So I remember looking at looking in the window, and all of a sudden I see him like barreling towards the door, and I tried to say, "Stop," and I wasn't quick enough, and anyway, so I stepped back. 2 kicks of his bare feet, and those doors are thick. They're like this thick. 2 kicks of his bare feet, and he broke through the door. And so it was me standing on the other side of the door and brand new CNA. So we both looked at nobody else was in the hallway. We both looked at each other like, now what? Anyways, but I looked at him and I got his eye contact, and I could tell he didn't really want to hurt anyone. He just didn't know what to do with himself. He was so manic, he did not know what to do with himself. So I said, "Come walk with me." So he's up here, he's like 6'4", and I'm down here. So we're walking, we're pacing on the unit, going back and forth, pacing. And in the meantime, I'm giving eye contact to the rest of that he couldn't see, of course, to the rest of my peers. Like, what do you think my eye contact would be like? Like, yeah, you got it, right? Like, help! Somebody do something here. So anyways, and yes, of course they did hear the 2 kicks and the door kind of flying off everyone heard that. So they did kind of see that I had it under control. I hit him and we were pacing, and that was good. That was keeping him busy. And so in the meantime then, while I was pacing with him, they were he was already in seclusion. We couldn't put him in another locked room. That wasn't going to work. So then they did have to end up putting him into restraints and then giving him some IM medication. But he ended up going into restraints for a while. But I kept him occupied the whole time. I was talking to him very quietly and just, it's going to be okay, and just reassuring and just kind of. So that was an interesting situation. So we want to manage their medications. We're going to be watching their lithium level if they're on that. We're going to be giving them PRNs, decreasing their physical activity. Now, so you're wondering, why was I pacing with him? Well, usually maybe I wouldn't be ordinarily, but it would be too stimulating. But he needed to do something. He just broke out of that room, and I couldn't just make him stand there while everybody got the restraint stuff together. So that seemed to work. But ordinarily, we don't want to overstimulate them. That is the most important concept to think about with somebody with mania. We don't want to verbally overstimulate them. Sometimes they may not even be able to go to group because it's too stimulating. There's too many people there, too many ideas. They get, very distracted easily. So we really want them to kind of lay low. And of course, then with that lack of sleep, we don't want to stress their cardiac system either. So we want to increase their food and fluid intake. They're too busy to sit down and have a tray. We might have to give them food on the run. Give them an apple, give them a banana, give them a sandwich that they can eat while they're pacing. You have to be really creative sometimes to get those nutritional needs met, because they may not be able to sit down and actually eat a meal. 4 to 6 hours, even that, how do you guys feel on 4 to 6 hours of sleep? It's like, crabby, did you say? Yeah, so to me, that's even kind of low. But if you're only sleeping 1 to 2, I guess 4 to 6 is better. But anyways, that's really an important aspect of care.
In
Yeah.
your experience, are people in mania not malice, like the man you were describing? So just have pent-up energy, but their intent isn't to harm another person?
Right. Yes, but sometimes people can become very angry and irritable.
Okay.
They
So
can.
See, as the caregiver, it would be a scary situation, if
Mhm.
someone were that urgent with their thoughts and things. But
Right.
if you keep in the back of your mind that usually
Right.
they're not intending to hurt someone. Or
Right.
you as their caregiver.
Right. They're not intending, but even the one, I think I told you about the person who put her arms around my neck and choked me. And truly, I don't think that she really wanted to hurt me, because she was looking for me. She was crying. She was saying, "Oh my God, Mary, I killed her." So I don't think she intended but sometimes they do act in a violent way. Yes. So they might act in a violent way, but I guess I did an instant assessment. I looked in his eyes, and you can tell a lot from looking at somebody's eyes. You really can. So I looked in his eyes, and I just made that instant assessment of he just doesn't know what to do with himself. He's lost. So that's what I gave him, something to do, and paced with him. So that actually worked quite well. So self-care needs, again, we're going to encourage people to get in the shower. They may not be taking care of their ADLs. So, all right. Let's see. Sometimes, again, people with bipolar, they have depressive episodes also, so they would need hospitalization if they are becoming suicidal and severely depressed, or if they become catatonic where they're not responding. All right, and we have to think about sometimes medication can bring on a manic phase. So when people are depressed, then if they're on too much of an antidepressant, too high of a dose, that can slip them into mania. It's really kind of interesting how, our aspect is monitoring and documenting, right? We're not the one prescribing the medication unless you're an advanced practice nurse, but we're monitoring. So if we can tell that somebody their mood is getting too high, then we would need to document that, maybe talk to the doctor about lowering that dose. So that can be a concern. And then honestly, I've seen ECT swing somebody from mania, or from depression all the way into mania. It was interesting. One guy was actually like a celebrity in Rochester. He was the manager of a sports team, and he was a local celebrity. And we were all very hush hush, keep his identity secret, and we were so careful about guarding his confidentiality. And then he was so depressed, and then he was instantly had ECT and became manic. So then he got on the phone and he was calling everybody, telling them he was in the hospital. And we were all like, well, so much for trying to protect his confidentiality. He's sharing, and we can't help that. There's nothing really we could do about that except maybe encourage him not to make phone calls. But anyways, so, all right. So we want to look at their agitation and their mood stabilization. Of course, that's what we're looking at. Medications, lithium. Do you have questions, Cindy?
Yeah, no, I just want to share with depressant.
Sure.
I was just surprised that my father-in-law had a 3-month stroke. He's 62.
Okay.
He kind of threw off his balance, so he can't walk by himself without a walker versus him being out and about. Now he's dependent on a walker. He can't focus.
Wow.
But it was just crazy though, because his physician, she asked him so many questions if he was feeling depressed. Which I was so surprised because she could you take somebody that's independent.
Yes.
Now he's solely dependent on somebody.
Yep.
So I was just surprised that she was concerned about that as well as his
good
well-being. She was just like,
good.
Do you feel sad and all these questions? I'm like, I'm really surprised she's asking any of this because nobody, people didn't do that. Yeah, sure, because God is independent, taken away.
Yeah.
Maybe he's sad now.
Yes. Excellent.
Yeah, and I'm like, my husband told me, and I was like, that's really surprising because you usually don't think a physician would go in that route. Their first would be let's treat them medically.
Right. That's excellent, because I do think that that's happening more and more in doctors' offices, that they are screening people for depression and suicidal ideation, because sometimes they're not going to go to the doctor for that, but maybe they are suicidal, they don't really want to share it, they're uncomfortable or feel stigmatized, but if they're asked the question, they're likely to share if they really are having that. So
which is nice, because not everyone felt comfortable sharing it with us.
Right.
Somebody gets it.
Yes, exactly.
Sometimes you only get one chance with your patient. They don't always
Right.
come back for routine medical care, so it's good to just look at the whole person. You think that you would maybe only seek one appointment, and you miss your opportunity.
Right.
You can't think, well, we'll cover that next time he comes in.
Yeah, my doctor, I don't know if this is everywhere, but there's every single time you go, you have to answer 20 questions, and it's domestic violence and depression and all
Oh, wow.
and,
Okay.
You wear your seatbelt, you have fire things.
Oh my gosh. Huh.
It's so annoying because my answer is the same every single time.
Yes.
And they always say, I'm sorry, it's going to be a while. I'm like,
But it's good though, because especially the depression or the suicidal ideation, because those things, maybe it wasn't happening at one appointment, but maybe it will another and not you
Yeah.
in particular,
Well, I know
but
that's why I
anybody,
do it,
you
but
know.
the other questions
Yeah.
like, do you wear a seatbelt and stuff.
Oh,
I'm not gonna like stop wearing a seatbelt, so.
right. You would hope not, anyways, right? But yeah, it's an interesting way to kind of get at people's safety. Yeah. Okay. Lithium. So lithium is always been the gold standard treatment for people with mania, especially the manic aspect of bipolar. Then it kind of fell out of favor for a while because there are side effects and monitoring that you have to do with it. But it's coming back, and almost everybody, we've given lithium tons of times already, just in my little 5-week lifespan group. So we are giving lithium a lot more. It is definitely indicated for bipolar. Therapeutic and toxic range is very narrow range. So in other words, you can go from therapeutic to toxic with a point something of a, you might think, oh, toxic blood level is 1.5, maintenance blood level is 1.3, 1.5 couldn't be that bad. Actually, you can get toxic less than 1.5, depending on your age and your medical status. I had a 90-year-old who got very toxic on lithium. So, very narrow range of therapeutic. It's interesting because somebody came in last week and they had their lithium level was less than 0.2 or something like that. It was just a really minimal amount. So clearly then we can tell somebody was what? Not taking their meds. They were not compliant. They said they were taking their meds, but they weren't because their level was really low. And then we just checked somebody else's level the other day and it was 0.9, which is at a good level. So in his behavior and mood seems to be kind of, evening out. But you really have to be careful with lithium because there are some contraindications. If you have certain cardiac conditions, you may not be able to take it. It does affect your kidneys and your thyroid functioning long term. So in addition to having a lithium level drawn, a serum level drawn, usually after they're stabilized, maybe monthly for a while, then it might go to once or twice a year to get that lithium level done. But you have to, you have to cooperate with getting those blood draws. Renal and thyroid, very important to get those done too, in addition to the lithium level. Contraindicated, absolutely, with pregnancy too. You cannot take that when you're pregnant.
Do they usually switch them then if they do get pregnant? Don't they have a chance of going into mania if a pregnant person's taking on lithium all of a sudden?
Well, if you're planning on becoming pregnant, they would probably wean you off of it because most of the harm would be done maybe before you even knew you were pregnant. So they would not even, if you're planning on having a baby, you would have to go off the lithium prior to trying to get pregnant.
But it would affect it well. If they accidentally did, it would already affect them.
Yes.
Okay.
So that's a good point. So you're saying, well, if you're taking them off the lithium, aren't they going to get manic? Yeah, probably. So they might have to do another, put them on a different type of medication. There's other mood stabilizers that they can use that might not be harmful, but lithium for sure is harmful. So you don't want anybody. Let's see, what else about lithium? There's all kinds of things. You have to have a stable intake of sodium. So we don't want to put somebody on a low salt diet. Okay, that would be the worst thing to do because salt has to bind with the lithium in order to excrete it. So if you go on a low sodium diet and you don't have enough sodium in your diet to excrete the lithium, you're going to get toxic. You're going to build up a too high of a level. So consistent level of sodium, moderate level of sodium in your diet, a good fluid intake, 2,000 to 3,000 mils should have a good fluid intake. I think you have to be careful in the sun also. Sometimes you might get excessive sweating. And actually, if you do a lot of physical exercise with excessive sweating, you probably should drink some fluids with, like Gatorade, something with some sodium in it. Again, you want to replace that sodium. Let's see. Anything else about lithium? It's just kind of you just have to be very careful. If you become toxic, it is just so very pronounced. Diarrhea, shaking, so somebody who is normally able to walk and talk, all of a sudden they're garbled speech, they can't walk very well, they have diarrhea, so some muscle problems. And so we always need to check a lithium level before we give lithium. We should never give lithium without knowing what that level is. All right, so we just kind of talked about the teaching that you would do, and they, of course, need to stay on it and not double their dose or, just the usual things that you would teach, but they really have to cooperate with getting their blood drawn. So we have some other anticonvulsants that are mood stabilizers. So typical ones are Depakote, Tegretol, and Lamictal, and we do see a lot of these in the hospital. I have never seen a Lamictal level, serum level, but I believe maybe some hospitals do that, but I have never seen one at Sheboygan Memorial. But I do see Depakote and Tegretol levels, because those also need to be in a therapeutic range. Sometimes we use antipsychotics, and we'll get into more of these antipsychotics when we are talking about the next learning plan after the exam, schizophrenia. But we do sometimes use it. If people are highly agitated or delusional, we'll definitely have them on any number of antipsychotics. Okay. First generation, we try not to use as much because you are getting more tendency to have tardive dyskinesia, which we saw at the hospital this week too. By the way, somebody is developing tardive dyskinesia after having schizophrenia for many years. Not good. Okay, so other treatments, again, ECT, sometimes that really works very well for depression. Health teaching, okay. Advanced practice interventions, kind of similar for most of the different types of illnesses. And we're always going to be evaluating the plan of care and revising it as needed. So quality improvement, standards for Bipolar Excellence Project, just that we do quality improvement. We do use evidence-based practice in mental health nursing, and new measures are being developed and tools to provide that. So little response question, which anticonvulsant medication might be prescribed for a patient with bipolar? So is that Depakote, Klonopin, Zyprexa, or Lithobid? Which one? Okay, it says which anticonvulsant. So that would be A. Yeah, that would be A, the Depakote. Lithium is kind of in a class by itself, so it's not considered an anticonvulsant. This is almost a little bit of a trick question because the benzodiazepines can be used for seizures. So Klonopin is considered a benzodiazepine. It could be used for seizures, but it's not classified as an anticonvulsant. So a little bit of a trick question. So I won't give you any trick questions, I promise.
So what does lithium fall under? It's just its own category?
It's kind of its own category as a mood stabilizer for treatment of bipolar, yeah.
So is the ones on Depakote for bipolar versus just seizures, are they on a higher dose, or is it kind of situationally based?
Situationally based, yep, depending on their symptoms. That's why we as nurses have to evaluate how they're doing with their mood behavior. Are they getting less manic? And then the doctor would adjust the dose based on their symptoms. Mm-hmm. Yep. So if you see Depakote, Lamictal, Tegretol, don't assume, on your list of meds, don't assume that they have a seizure disorder, because I'm guessing most of the time when we are giving those meds, we're giving them for the mood stabilizing aspect rather than the seizure. All right, so chapter 14. So according to the Kahoot, you guys are really good with knowing already what a lot of those symptoms are. Sadness, emptiness, they could have irritability, bodily concerns, perhaps impairment of thinking. They all affect a person's ability to function. And just a little bit of a slide, the next one too, and delirium, dementia, and depression, because sometimes they can seem a little similar and overlap. And it is a competency to kind of distinguish between these three. So just one little slide about this. So delirium is a sudden onset. And again, you've probably seen that in the nursing home, right? When the person gets a UTI, you're shaking your head, smiling like, yeah, all the time, right? So they have a sudden change in their behavior, and do you have any descriptions of what people do when they're delirious?
Someone that's just usually calm will also be running out of their wheelchair, and they usually can't walk, or
oh wow, okay.
You hear things that
okay.
just don't make any sense.
Yeah, they start, sometimes they're talking nonsense, and usually they're okay cognitively, or they're picking at the air, looking at things, or picking things out of the air. So, and the causative factors usually are medical in origin, could be a side effect to medication, digitoxicity, and it is reversible, okay? Dementia is not reversible, and usually it's a very slow onset. But then if we look at depression, depression is reversible also, and the onset might also be gradual. So, we had a patient last week who actually, they were kind of, let's see, he was only in his late 50s, but they were kind of thinking, does he have dementia, or is it depression? Because there's so many symptoms that kind of overlap. So, usually, the forgetfulness, the inattention, the difficulty concentrating can make you kind of think that person's getting dementia. So you really have to do very careful assessments. But it is reversible with treatment. So that's the good news. So major depressive disorder, we have other mood disorders that we'll talk about too. And one they don't really have on their slides from the book would be seasonal affective disorder. And we'll talk about that a little bit when we get to some of the treatments. But that's something that, now at this point now the days are getting longer. I mean, it's light longer, you know what I mean? So if somebody has seasonal depression, it might even start to be getting a little bit better by this point in time. But when was it November that we turned the clocks back? Was it November? Yeah. So from November kind of till now, if anybody has seasonal depression, this would be kind of a bad time of year. All right. And we'll kind of look at those in a little bit. So, little case study, a 19-year-old brought to the hospital after a suicide attempt. Parents found him in his backyard wearing his favorite black jeans and black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time. He has just been admitted to your floor for a 24-hour suicide observation. Okay, so we'll get back to him in a little bit. So let's talk about some of the other depressive disorders. Major depressive disorder, of course, is the most common one. We also have something called persistent depressive disorder, used to be known as dysthymia. So whenever you see DYS in front of something, a medical term, what does that usually mean? Anybody know? Because you probably had other medical terms that begin with DYS, like dyspnea. What else? What are there? Difficulty? Yeah, dyspareunia, dyspnea. There's other dys words. So dysthymia is like a difficult mood, a bad mood. So it's a chronic bad mood. And it's usually there for at least 2 years for adults. Wow, that's a long time, right? So that's somebody who's chronically depressed, but usually not severe enough to end up in the hospital. They certainly would benefit from meds and treatment, therapy. But they usually are functioning, but maybe not functioning as well as they could be. Okay? So that's kind of what that is. And they have some of the same symptoms that you do for major depression, but just a little bit less severe. But yeah, to be depressed for 2 years. Premenstrual dysphoric. So again, dysphoric. So that dys word again. So symptoms cluster in the last week prior to the onset of a woman's period. So mood swings, irritability, depression, anxiety, overwhelm, difficulty concentrating, and they decrease significantly with the onset of menstruation. So other depressive disorders, depression can be induced by substances. Okay? So in other words, the person doesn't experience those symptoms in the absence of drug or alcohol use or withdrawal. So ordinarily, if they're clean, they're not going to be having those symptoms. But it's only when they're using, abusing, or withdrawing from a substance. And there can be depressive disorders associated with another medical condition. So depression can be caused by kidney failure, Parkinson's, Alzheimer's. How about thyroid disease? I had a student once tell me that they were diagnosed with depression when it actually came to light that after having some further medical testing that they were hypothyroid. So if you're hypothyroid, you're going to look like you're depressed. And that again is very easily treatable. You get on thyroid replacement and those symptoms get better. So actually, in the old days, I don't know if they do that now, but we used to test every single person that came into the hospital with depression for thyroid, just to make sure that that's not the problem. So that's a pretty easy fix. And you can also have other major problems with other types of illnesses, such as how about a new onset of cancer? People get depressed when they have a difficult diagnosis, a new onset of MS or something that's kind of devastating. How about Lou Gehrig's disease, ALS, right? Something that's going to change your life. Or an amputation. Somebody has something amputated or surgically removed. You can have depression symptoms related to that. So again, the major depression, you got most of these from the Kahoot, but 5 or more of the following: weight loss and appetite changes. It can be usually significant weight loss, like 20 pounds in a month or something. It's pretty significant. Some people gain weight and they actually eat more when they're depressed, but most of the time it's weight loss. Sleep disturbances, so they don't sleep very well, and the typical sleep disturbance is early morning awakening. So they fall asleep and then they wake up at 2 in the morning and then they can't get back to sleep. Or maybe they do for a little bit, but then they wake up again at 3. So so they really have a difficult time with sleep. So then they're feeling fatigued. They feel worthlessness, guilt. They feel like they are the worst person in the world and their family shouldn't even love them. That's literally how bad they feel. Do you think that girl with her hair, do you think she had any of these symptoms? Worthless for sure, right? I mean, just to feel so worthless that you just don't even comb your hair, and then just to feel like, oh, just chop off my hair, don't even bother with it. Definitely worthlessness. Loss of ability to concentrate. I would bet she wasn't doing well in school. Recurrent thoughts of death. Didn't say anything about that, but you would certainly worry about thoughts of death, all the way up to passive thoughts, all the way up to active thoughts about ending their life. And then that loss of interest in things, anhedonia. So, all right, lots of symptoms. They usually persist for a minimum of 2 weeks to 6 months. So the Kahoot was about right. If things aren't going better after about a month, time to see somebody. So chronic, again, lasting more than 2 years. It is common to have recurrent episodes. Once you have a major depressive episode, you are likely to have another one, especially if you go off your medication. So that's a big selling point for people to keep on their meds. If they stay on their meds, they may not have that second episode, or it may be a little bit less severe than that first one. So distress and impaired function, for sure. People can't go to work. They can't get out of bed. They can't do anything around the house. They can't do their yard work, whatever you do, people find it really difficult. So based on some of those symptoms, what do you think the stigma associated with depression would be, and what do people think of, in the general public, how do people think about people with depression? Right. Yes. Why can't they just get over it? Mm-hmm. Uh-huh. Right, exactly. Yeah. Mm-hmm.
Maybe they're trying to avoid, they're using it as an excuse to get out of doing something in their life.
Sure, absolutely.
In general, I think sometimes the perception is.
Yes, definitely. Or they're lazy. Why are they just laying around doing nothing? They're just lazy. They just get up and do it. And people don't understand that it is an illness, and they truly can't. So, all right. Let's see. It is the leading cause of disability in the United States. So maybe that's surprising to you. Maybe you thought heart disease or cancer was a leading cause of disability, but lots of hours of work lost because of depression. And children and adolescents experience depression, and then, of course, they're having trouble with school. Older adults, you're going to be looking at older adults a little bit differently. It is, thinking about the lifespan. It is not typical. It is not something that's to be expected that you get older and you get depressed. It's not part of aging. It's not a normal part of aging. It is something that happens, though, but we do have to think about our older adults as not being able to always tell us that they're depressed, but we may look more at their behaviors. Okay, so again, the eating and sleeping. So they may not be able to say, I'm sad, I feel depressed, but you're looking at changes in their eating and sleeping, changes in their concentration, their mental status, and maybe, no, they're not getting more demented, perhaps they're getting depressed. So we do have to assess them very carefully. Lots and lots of comorbidities with depression. And the biggest comorbidity really is anxiety, because depression and anxiety kind of work with a lot of the same neurotransmitters in the brain. So lots of crossover between those two symptoms. And pain is actually, as far as medical conditions too, pain in general, it's not a diagnosis per se, but it's the consequence of lots of different types of diagnoses. People that have chronic pain have an enormous amount of depression, and sometimes to the point of being suicidal. There was one patient that just could not get his pain under control and actually tried to commit suicide on the unit. It was like at the change of shift, and this guy was serious. It was at change of shift, going from second shift to third shift. And so there's not very many people around, and kind of timed it and just tied something around his neck. And I don't know if he tied it or looped it over the end of the bed, kind of pulled the covers up, so it was kind of hidden. And somebody very astutely, kind of lifted the covers up when they were doing rounds, rather than just peeking in and going, yep, they're okay, And so a CNA found him, and then they had to go get the cutting thing and cut whatever he had tied around his neck, and he was okay. But it was because his pain wasn't under control and nobody was doing anything about his pain. So we have to take that seriously as a huge comorbidity for depression. So getting back to that case study, during intake, Jeff doesn't speak much, but his parents are able to list the following symptoms. And again, those are the ones that we kind of talked about already: constant sadness, and that loss of interest in things, loss of interest in his college classes, and even online games, so that anhedonia. So if people have a sudden disinterest in things that they usually really enjoy, that's a huge clue that they're depressed. So, and it's anhedonia. The other ones are kind of, I don't know where they got those other words from, but anyways. So that anhedonia, that's a big symptom of depression. So lots of different reasons why, again, genetic, lots of different, alterations in hormones and cognitive theories. We have assessment tools that we use for depression, and especially we have to assess suicide potential. They're doing a Columbia suicide assessment on the unit. And they're asking every single shift. You'll see it documented. I don't expect you guys to do it. The nurses are doing that. They're very specific questions they have to go through to assess their suicide potential. And you'll see it when you're looking in Epic. And they are, every single shift, they are going through that with somebody to assess their suicide potential. It's a huge drive right now with Zero Suicide to really try not to have anybody commit suicide who is in treatment. So again, okay, key assessment things, we kind of talked about those. Oh, we didn't talk about vegetative signs, so I'll just tell you what those are quick, and then we'll take a break. So anybody ever hear that word before, vegetative signs? Did you see it in the book at all, or remember the vegetative signs of depression? It's actually, that's part of it. It's the bodily signs. It's the bodily signs of depression. So it would include the lack of sleep. It would include the lack of, the lack of eating, constipation, sex drive, lowered sex drive. All of those things, the bodily symptoms of depression, are considered the vegetative signs. So you may see that sometimes in the physician's notes, kind of describing that. So that's the bodily symptoms of depression. Okay, so why don't we guys take a little quick break, and then we will finish this up.
It's always when you completed tablets before. It's always
All
when you, like,
right.
question yourself
No, I'm
if
starting to
you're
get annoyed
actually
because the last 2 semesters I didn't study, got high 80s, 90s. This
Oh, fluid and electrolytes are hard. That's hard. That's
I
hard
think it's
stuff.
like too much and they all just like overlap.
Yeah.
the first test
They all overlap. I was like, I swear, like maybe when you start connecting the overlaps, it
Yeah.
makes sense. But it's like, oh, this is
Okay, back to mental health. No, sorry, we got it. Back to mental health. All right. So all the things to assess their mood, their feelings, physical behavior. We didn't really talk too much about that. So many times people are in bed all day, right? You're going to be frustrated working with somebody with depression because they're going to want to be in bed all day. They don't necessarily want to talk to you. They want to kind of be by themselves. And so, we have to really kind of work on them that way. Or they could be pacing. Okay? So they could have some pacing, like kind of going along with their anxiety that goes along with the depression. But most of the time, people are going to be at a lower level of physical activity than you would want them to be. Alrighty, let's see here. Alright, so again, we talked about age considerations. With kids and adolescents, the thing to assess would be their school performance and their peers. If they're actually engaging with their peers, if they're doing okay in school, if their grades all of a sudden tank, maybe it's depression, could be drug abuse, something is going on, need to kind of figure that out. And again, if they have that, all of a sudden they were involved in extracurriculars and all of a sudden they've dropped off the swim team and they've dropped off of this and that and they're not doing anything socially with their peers anymore, that would be another big clue for kids and adolescents. And then older adults, again, we have to assess their behavior because they're not necessarily going to tell us anything. And that self-assessment is, again, looking at the stigma that we might have, that we might think, well, why can't they just get up and do that? If we don't have an understanding that it's an illness and that they really can't get up and take care of themselves, then that could make us very frustrated. It also is frustrating when somebody doesn't want to talk to you. If they're just in their bed all day and they go like, nope, go away, don't want to talk. Sometimes it is helpful as an intervention to stay with somebody. Okay, try to stay with them at least for a little while because you're giving them your nonverbals are showing that you are interested in them and you care about them. If you say, oh, I care about you, they're probably thinking, well, who are you? How do I really know that you care about me? But if you sit there with them, sometimes they actually do start opening up. So that is always a really good intervention. Even if they don't say anything, just try to sit there for a while and just be available to them. All right. So which question would be a priority when assessing for symptoms of major depression? Tell me about special powers you believe you have. You look really sad. Have you thought about harming yourself? Your family says you never stop. How much sleep do you get? And do you ever find that you don't remember where you've been or what you've done? B, I'm hoping you say B. Definitely that would be a high priority for when people are depressed. So some nursing diagnosis, risks for suicide, and again, that would always be that highest priority, would be that safety. People are hopeless, ineffective coping, social isolation because they stop seeing people, they stop socializing. They might have spiritual distress and definitely self-care deficit, as you can see by that girl with the hair. And I've seen other people honestly like that. This one guy came to the hospital. I thought he had dreadlocks. I really did. I thought he had, because people do have dreadlocks, and that's done purposefully. This wasn't dreadlocks. This was matted hair that looked kind of really similar to the pictures of that girl. So we do have to look at that. We want to always focus on the patient's strengths, and treatment goals should be mutually developed based on the person's personal needs and values. So think about CUSIN, patient-centered care. And we have to plan what we're going to do based on the phase of depression that they're in. So if they're really very, very low, we don't want to put a lot of expectations on them. Okay? Because if we have a lot of expectations, they're going to feel even worse if they can't meet those expectations. So if we say, get up at 8 o'clock, shower, get dressed, brush your teeth, go to breakfast, go to every single group. You know, it's like, that might be overwhelming. So we might have to set some really very short, manageable goals. Yes?
With one of my patients, I had her for 2 weeks, and the highlight was she got out of bed. I think
Yes.
that was the highlight.
Yes,
Like, it wasn't
absolutely.
like you could plan for your nursing guidance like a 10, she wasn't an 10.
Right.
And the whole point was like, I think my other patient, it was like, go to the dining area to get her tray.
Mm-hmm.
She doesn't have to eat there, like she just has to go in and show
Yep.
the initiative of getting her tray. And
Yes.
I think it's just a small step that.
Yes, very small. Yes, those very small steps.
Like, it's just a progression. Like, you wouldn't see it as a normal. Like, you're like, oh, that's
Right.
a progression. I'm like, no. The lights are on in her room. That's
Yes.
a deal.
Yes. So if having the lights on in the room might be, that's a goal that they just met, or just getting up out of bed. Excellent. That is really a very good example of setting those small goals. So, and now the phases of depression in that first acute phase, hopefully if they're in the hospital, they're not going to be there 6 to 12 weeks, but the acute phase can last 6 to 12 weeks. So I guess that we have to think about too, you know, are they safe to go home? Personally, I think that's a huge responsibility that we have. We have to really assess that people are not suicidal when they're leaving, because they certainly can be in that first acute phase. Now they're starting on an antidepressant medication, so by the time they're going home, the antidepressant may not be fully 100% effective. Okay, they're starting to feel better, and hopefully they're safe, but that doesn't mean they're clear and free and clear. So we have to really encourage them to continue to take their meds. And we have to realize that they're still very high risk for suicide, because sometimes when people are super depressed, like Sandeep was saying, if they're in their bed and they can't even get up, like it's a big goal that they got out of bed, they're not going to have the energy to commit suicide. But when the antidepressant starts to work, their mood starts to get a little bit elevated, they start to get a little bit more energy, but they might still be depressed. And then they have the energy to commit suicide. So we do have to really watch that really carefully. The other two phases, basically, we just need to, we're not going to see people in the hospital, you know, at the 4 to 9 month period or the year period. We don't keep people that long. But we have to, again, remember to encourage people to stay on their meds, because if they go off their meds, they're likely to have a recurrence. And so it's really important, even if they're feeling better, because we all know, even in the medical side of things, people stop taking their meds because they feel better, right? People stop taking their antibiotics early because they feel better. So we just, again, have to keep incorporating that into our teaching. So counseling and communication, again, sometimes we may not be able to sit there and have a great conversation with somebody, but perhaps they're only going to say a couple of words. So we have to convey through our behavior that we are concerned about them and that they are worthy of our attention, and they are because they don't feel good about themselves. So we have to convey that through our nursing actions. Health teaching and health promotion, just general health promotion behaviors that could help with depression, such as if people are having a healthy diet, healthy lifestyle, engage in some exercise. All of those things do help you to feel better overall. So, all right. And when the physician is choosing an antidepressant, they're looking kind of at the symptoms that the person has and possible side effects. Because if somebody is, perhaps if they're newly married and they want to have children and something has a lot of sexual dysfunction, they're going to maybe pick something else. Or weight gain, you know, to either, if somebody is super thin because they've lost a lot of weight, there are some antidepressants that maybe can cause weight gain, and that can actually help them to even that out a little bit. So there's actually, I think they're getting more savvy with trying to figure out ways to get that best antidepressant first rather than trial and error. A student was telling me yesterday that there is some kind of a cheek swab that they're doing that's in a clinic where she works, and then they can tell genetically, they can tell which medication is going to be effective, which I think is great. I mean, because we don't have a lot of diagnostic tests that are verifiable. You know, we don't have a blood test for schizophrenia. We don't have a blood test for depression like you do with some other types of illnesses. So if we can get to that, seeing what genetically works for us. Or if you have a family member that's on Prozac and that works really great for them, they will probably pick Prozac because that you're genetically likely to respond to that medication too. So I just think that's kind of an interesting thing to think about. So the SSRIs are some meds that we use in depression, and that's usually the first line of therapy. So those are the ones that are going to be picked first. And there is a rare risk of serotonin syndrome. Usually if they're on more than one medication that affects that serotonin system, then that puts them at increased risk. But if they're on one medication, it's not really something that is likely to happen. There's SNRIs. They might be tolerated a little bit better as far as side effects. The tricyclic antidepressants, there's a lot of anticholinergic side effects. They're actually very cardiotoxic. So if you have heart disease, you shouldn't be taking them. And if somebody overdoses on a tricyclic, it is likely to be a deadly overdose. Versus the other antidepressants, it's not as likely to cause death. The MAO inhibitors, I don't see those used very often. Usually if somebody has unconventional symptoms or if nothing else works, they might try MAO inhibitors, and then if that doesn't work, they might go to some of the other ECT or something like that. But do you remember from pharmacology what type of diet people have to be on for an MAO inhibitor? Does that ring a bell at all? Yeah, yes. The cheese and beer, the Wisconsin diet. Yeah. Sausage, cheese, beer, chocolate is in there too. Yes, tyramine. Low tyramine or no tyramine. Very good, excellent. I'm going to tell Jill you guys are, you and Jill, right? I'm going to tell Jill you guys remember that.
Please do that.
I will, I'm going to. So you have to be compliant. You have to be compliant, right? You have to be really willing to keep away from all those foods. And I think it's even like ripe bananas, fig. There's a bunch of things on there. And if you're not willing to change your diet, and again, it's kind of, part of it's like a Wisconsin diet. So we have to kind of think about that. So, because if you do have any of those foods or medications, it actually interacts with a lot of meds too. What is the huge, serious response that you get if you eat those foods with high tyramine, or if you have medications that are interacting? What is the serious consequence of that? See if anybody remembers that. Hypertensive crisis, yes, which could mean a stroke, right? Could lead to a stroke. So your blood pressure goes way out of whack. So, again, you have to be careful who's taking these meds, because if you're not compliant, or if you're suicidal, some people have been known to consume large amounts of tyramine foods as a suicide attempt. Okay? Yes. Or as a self-harm attempt. So, just some things to think about. So, some other things, ECT, transcranial, magnetic, and I think I've got a couple more slides on these. So, again, it is used, it's very effective, and it's actually considered safer than the medications. So if somebody just can't, they really can't get out of that depressive episode, meds aren't working, or they're just so severely malnourished, exhausted, dehydrated, then they may do ECT to kind of bring them around quickly. Can be used in schizophrenia and catatonic episodes. And it's like a little mini surgical thing. It's not surgical, but I mean, they give you anesthesia, muscle relaxant, and it's like inducing a seizure. Transcranial magnetic stimulation is non-invasive, uses MRI-like magnetic pulses, and that can help with depression. Cindy, if you have a question.
Especially if they're putting you under anesthesia.
Okay. How often can you do it? When you start out, it's usually 3 times a week, like Monday, Wednesday, Friday, for a couple of weeks, for like 2 weeks. Okay?
Is it like a low dose of anesthesia?
Yes, it's a very short-acting anesthesia. Okay. Very short-acting. And the muscle relaxant, too. And they have to bag you during that because you stop breathing.
Right.
So but it's very, very, very short-acting.
Okay.
I don't remember the name of the exact medication that they use, but it is very short acting. So they come out of that very quickly, within minutes. No, it's right, but it's 3 times a week for 2 weeks in a row usually. So it's like 6 treatments, boom, boom, boom. And then after that, people are on maintenance and they may go for a treatment once a month. So, all right, so transcranial magnetic, the only thing is if you have metal in your body, then it's not a good thing. So there might be a little bit of some side effects, but that's just another kind of newer. Don't know that it's available in this area at all. Same thing with vagus nerve stimulation, and that's originally to treat epilepsy, and there are times when patients are receiving that. Deep brain stimulation is invasive because you have surgically implanted electrodes, and again, for people that aren't responding to anything else, that would definitely be something that would be better than being depressed and unable to function. Light therapy is a first line of defense for seasonal affective disorder. So, and you can order those online. You can just do it yourself in your own home, or you can go to an office and get treatment. They have a beautiful light box on 1K, but they never use it. It's a beautiful box. It's just huge. And anyways, so could be a negative effect of headache and jitteriness, or actually if you do it too late in the day, then sometimes you are too stimulated and you can't sleep very well. So it's usually first thing in the morning when you get up.
I don't think I've ever seen it used there while we were there.
No, I've seen it used very rarely. Very rarely. So St. John's wort, I wouldn't call it a first line of defense, and actually I've read articles where it's not even, people I think would like to try to use natural methods instead of medications, or think that they can just cure it on their own without going to a doctor. So St. John's wort was really popular a few years ago, but it probably doesn't, from what I've read, it probably doesn't really do a whole lot. It might help as a supplement, but certainly not as a first line treatment. Exercise, again, is great. It's helpful, but if somebody is severely depressed, this would not be the only treatment you would do. But exercise certainly can help because it does help with that serotonin. Advanced practice interventions, therapy, different types of therapy. Improving screening. So again, Haley, you were talking about the doctor's office and being screened like continuously, and I do think that is a big part of Healthy People 2020 is getting more kids and adolescents screened, getting more adults screened, so reducing those episodes because it's a really debilitating illness. So we're always going to evaluate their suicidal ideation, evaluate if their intake is better, their sleep, their personal hygiene and grooming, self-esteem, social interaction. And again, it can be in very small steps, but even a small step of, hey, they got up today, they put their light on in their room for the first time today, that is a significant improvement that we're evaluating, and we need to document that. All right, so national goals of health, again, Healthy People 2020, this is definitely a goal, increasing the percentage of individuals who receive treatment. Of course, if we have psychiatrist shortages, that doesn't really help. And now we do have a shortage here in Sheboygan. Well, we're not in Sheboygan, but I live in Sheboygan. But we don't have a child psychiatrist anymore. The adolescent and child unit is closed right now because we don't have one. It's really kind of sad. And I just read an article last night saying that there is a shortage in Wisconsin as a whole with child and adolescent psychiatrists. It's just a subspecialty. Yeah, it's a subspecialty that just not very many people are going into, and Dr. Norris just retired, and we don't have anybody to replace him. They are working on it, and they're hoping to open up that unit this summer, but it's kind of sad if you have a child or adolescent that needs some help. You've got to go to another city, and then just think what that waiting list might be like, to get in and get an appointment. So, all right. Oops, I actually have a couple of blank slides here. I'm not sure why, but did it print that way too for you?
Yeah. Oh, yeah.
Whatever. Okay. Suicide is the intentional act of killing yourself by any means. Ideation is thinking about it. Completed suicide is that successful, that's not a good word to have. So we don't want to say it's a successful suicide, but it means that a completed suicide is that it resulted in death. Non-suicide self-injury. Some people injure themselves. It is not the intent is not to commit suicide. The intent is to induce relief from a negative feeling to achieve a positive mood state. Has anybody ever worked with anybody that self-harms? That cuts or...
I had a friend that I found out was recently cutting.
Okay, it's really common. Do you have an example? You have a friend who does that? Yeah. So when they cut, what did they say? What did they say about it? Did they?
Yeah, I think
She feels relief.
Like to a point she can't take it anymore.
Okay, so
That helps.
yes, she gets to that point, and then that helps. So, but that's clearly it's not a positive coping mechanism, right? But it is a coping mechanism. The intention is not to kill themselves. And that may be hard to understand, but it's actually very common in all age groups. So we might think about teenagers or young adults, but all age groups. And there's actually a lot more cutting among college students than we'd like to think about. And also middle age, and I've seen older adults cutting and doing self-harm. So we have to think about it. It's all ages, both male and female. We had a patient recently, 45 years old, I think he is, and has some chronic alcoholism and personality disorders, and they give out those little golf pencils, what you can't do a whole lot of harm with, but he was cutting himself and scratching himself with a golf pencil. So we had to take that away from him. So a lot of people self-harm. Suicide is the 10th leading cause of death in the United States. Okay, that's huge. Absolutely huge. And then I'm not going to ask you different, statistics about the age, groups and things like that. But the thing to really understand is that middle-aged men are going to be at the very highest risk. Okay? Middle-aged men, highest risk. And it's active duty, suicide rates among active duty service members. So we really have to think about our military and veterans as far as being a high suicide risk. And that's unfortunately increasing. And when you're in clinical, I do a QPR presentation for you also, and you're going to be surprised at how our suicide rates are actually increasing. They're not decreasing. They're getting worse. So we have to do something about that.
It's crazy.
Yes.
My husband, when he moved here, he was so surprised that the homelessness and suicide rate is so high on the veterans.
Okay.
Especially like in countries like in India, like they do such thorough training before they actually send their soldiers off to war. Like they get extensive training where it's physical, mental. They have to pass so many things before they actually consider. First, like you have to go through so much to even enter into their army. You just can't sign a paper and be into their army. You actually have to be selected, pass everything and mentally prepare you before letting you go into the army. And it's also like a life, like they take care of you lifelong versus like you can't just put 2 years and be like, oh, I'll opt out.
Yeah,
like, you can't do that there. It's like a
interesting.
Like, but their race, it's like one of the leading for their army because they prepare them so well before they become So if somebody does have a mental illness,
that's great.
They won't let them in the army.
Wow.
That'll just make it work.
That's great. Yeah.
He's like, I'm so surprised that your veterans aren't taken care of here at all. And I'm like, it's because 18-year-olds going to war. There, you have to be mentally prepared to go to these wars.
Yeah, that would make sense. That's a great example. The other group that's really high risk, I've been reading some articles recently. Does anybody know another high risk group in Wisconsin, especially?
Adolescents?
No, I'm thinking about a particular occupation.
Nursing students?
No, no, it's not nursing students. Farmers.
Oh, yeah.
Farmers.
That's like a world thing, though.
Yeah, it could be. It could be a
it
world
is,
thing.
too.
Okay, all right.
Farmers are one of the highest.
Farmers. Oh, yes, I've read some articles. Very high risk. Isolated, and they have a lot of financial problems. They're in debt, and they don't want to leave their families in that type of predicament. So some of them actually contemplate suicide because then their families, they'll get the insurance money and their families will be well off or better off. Yes, it's really sad that farmers are, that is a huge, huge risk group. Okay, people that are transgender and people that are in the LGBTQ range are also very high risk. So there's a little case study about somebody who feels that they were, I was meant to be a girl, born as a boy, 14 years old, Gino. So in the meantime, he's asking people to call him Gina. I grew up with these kids, so to my friends, it's no big deal. But sometimes then when they get into other situations, they can have trouble. So growing up in a small neighborhood, now entered a larger school, doesn't always have classes. Gina, who dresses and grooms as a girl, tried to use the girls' bathroom. Teacher called her out on it, shooed her back out, calling her disgusting. So, people that have those issues are absolutely also at very high risk. So having a psychiatric disorder, having a verifiable diagnosed mental illness puts you at high risk. Alcohol or substance abuse disorders lower your inhibitions, put you at high risk. Some people, this one guy in particular comes in and he always will drink alcohol and use heroin before he does a suicide attempt. It's almost like to give him a little bit of courage to get over the fear of committing suicide. Male gender, increasing age. So again, middle-aged males, the highest. Race, Caucasians, 85 to 90% Caucasians. Religion, marriage, profession, physical health, all those factors can, we can kind of think about factoring all those in. Some people with very strong religious beliefs, that might be a protective factor that would protect them, keep them from committing suicide. And marriage, being married usually is a protective factor, although there are people that are married that do commit suicide. If you are in more of a white-collar profession, you're actually at a little bit higher risk too, just because of the stresses and pressures of that position. And if your physical health is declining, that certainly will put you at high risk. So, family tendency. So when we hear in report that so-and-so has 3 family members that have already committed suicide, wow, family history is a huge predictive factor for somebody that's going to commit suicide. Lots of different theories, Freud, Menninger, whatever. Copycat suicides, there are sometimes people that may not have a mental illness, but somebody else committed suicide, and then there actually are people that talk about a suicide pact, they'll commit suicide together. So we have to kind of think about that. The copycat behavior, usually that will occur mostly in high school age. They copycat other people for eating disorders, for self-harm, and sometimes for suicide attempts. So again, the youth and bullying. I do want to stop and show you a little bit of a video. Suicide, the ripple effect. I would highly recommend that. It was really, really quite powerful. So, bullying. Do adults bully each other too? How do we bully each other? How do adults usually bully each other? I mean, there's probably more than one way, but
I'm sure just jokingly they can come up with it. On social media, especially now that you point it out, that's so true.
Yeah. Yep.
Social media is such a huge impact.
Yep.
Because you hear so much cyberbullying.
Mm-hmm.
That didn't exist when I was in elementary school. I could only imagine if you're struggling with it in school.
Right.
But now you have something at the top of the finger and you constantly see that and use that at all times.
Right, and I think that's kind of the point he was making too, that usually if you're bullied at school, you go home and you're in your own safe space, right? But now that safe space is being invaded because 24/7 you can be bullied on social media. And adults bully each other too. Sometimes comments are just so nasty, and it's like we hide behind that anonymity of being behind your screen or whatever, and people are just very vicious to each other for some reason. Not sure why that's happening, but it does seem to be kind of more prevalent. There certainly can be adult bullying in person too, sometimes in a work situation. You might get bullied by another nurse who's had more experience, who might not remember what it was like to be a student or a new grad. You might be bullied by physicians or some other healthcare professional. So it's something that we all have to kind of think about. The other thing that's interesting about online is I have a friend who's a psychologist, and he said he's noticed in his practice that Facebook has really had a detrimental effect on a lot of his patients, because you look at some people's lives and it looks like everybody posts these things that are like just beautiful. They're on this beautiful vacation and they're posting all these pictures, or their children are getting all these awards and they're like the highest one in their class, and they're just, you know what I mean, just like all the, and then you look at your own life and you're like, ugh, right? So you can actually, he says he sees a lot of people really negatively evaluating themselves based on other people's glorious lives that they're posting on Facebook, and they're feeling really bad about themselves. So
you see it, my husband, like, that's one of the reasons he doesn't want a Facebook. He's like, why look at somebody and realize like you don't have it? He's like, and it makes you like not happy with your own when you perfectly could, because there's somebody else that has it.
right, exactly.
He was like, that's what was his social media. He's like, I don't want it because it highlights that.
Yeah,
When that might
yeah.
not be the case.
Yeah.
They might be posting pictures of them going out, but they could be.
Yeah, and like honestly, I personally, I'm on Facebook, but I personally don't like to, like if I go on vacation, I don't post pictures.
Yeah.
I don't post pictures of my every move. I don't really, honestly, I don't really think I post any pictures at all. I just feel like, I don't know, I just don't want to. I have a particular family member that I know would feel probably very upset or jealous because they can't go on vacation and I can. And you know what I'm saying? I don't like to do that. I don't like to flaunt something I have that somebody else doesn't have. But there are a lot of people that just kind of post their every move and what they're eating, and that can make people just, you know, a little bit more, yeah. Okay, so we could talk about that for an hour, but we can't. So, but we do have to think about the LGBTQ, whatever. There's a lot of initials now added onto that, but we do have to think about them as really being particularly vulnerable to bullying and depression as a result of that. We do have some protective factors in different cultures. So African Americans, usually if they have very strong religious beliefs and that extended family, they're so connected with each other. Same thing with Hispanic Americans, that connectedness with that in that extended family, and possibly again their religious beliefs that might protect them. And Asian Americans, adherence to religions that tend to emphasize the interdependence between the individual and society. So those things might keep people from committing suicide. We do have to look at our societal factors of like assisted suicide, and just culturally, as a culture, what do we think about life and how do we value life? The Netherlands, Belgium, and Switzerland have had assisted suicide, has been legal actually for many, many years. And in the U.S., there are some individual states that can allow, regulate, or prohibit assisted suicide. So it's kind of up to the state. So as far as the actual definition, according to psychiatrists, the DSM-5 excludes religious and political suicides from its criteria. So suicide bombers would not be considered in. They don't consider that a true suicide because they believe, their belief is they're sacrificing their life for a good cause. So that's a little bit different than ending your life because you're not happy with your life. So we do have to look at the number of suicide attempts, because if you have one attempt, you're at risk to make another. And if people have had multiple attempts, they are at very high risk to keep attempting and then possibly to have a completed suicide. So only about 56% of reported attempts receive adequate mental health treatment. I've heard stories of people going to the emergency room and I don't think they pump your stomach anymore. I think they just give you activated charcoal, but after an overdose, and then sending them home again and not hospitalizing people. So sometimes if there isn't adequate follow-up, they're very likely to make another attempt. And to have suicide behavior disorder, you have to have an attempt within the last year. Attempt was not initiated in delirium, or 24 months. I'm sorry, that's 2 years, right? Attempt was not initiated in delirium or confusion, and it was not undertaken for religious or political objectives. Verbal and nonverbal clues. Some people are very open. You're going to find when you talk to your patients about suicide and you ask them, they're going to be very open and tell you, okay, that they have suicidal thoughts and plans. They may not tell you their plan always because maybe they don't want to be interrupted, but they usually will tell you very clearly, yes, I'm thinking about driving my car into a tree. Okay. Covert statements are more subtle, more like, well, you won't have to worry about me too much longer, just things that are more vague, but not coming right out there and saying, I'm going to commit suicide. We have to look at the lethality of the plan when we're assessing, and our own self-assessment about how do we feel about people that are suicidal. Again, are we thinking they're weak? Are we thinking that they just don't know how to cope, and why aren't they coping better, and how could they be so selfish? That's another big word that we like to say when people are suicidal. They're just being selfish. So if we have all those attitudes, then that's not going to make us very therapeutic. So we do have to look at that. As far as lethality of a suicide plan, what do you think is the most lethal type of suicide attempt? Or a couple of the most lethal? What do you think? I'm sorry, what?
Like jumping off a building or something?
Okay, jumping off a building or something, or actually jumping up like Kevin Hines did. He jumped off the Golden Gate Bridge, which most people, very few people have lived, and he is one of the very few. Like, I don't even know how many, but probably a couple have lived. So yeah, jumping off a high place would for sure be lethal. Anything else?
Overdose.
Actually, overdose is considered non-lethal. It's considered a non-lethal method, although a lot of people do die from overdosing, but it's not as lethal. Guns, for sure. And there's hanging, yes. Yeah, guns, hanging, and jumping off of a high place would probably be the most lethal. Sometimes staging a car accident can also be. And then non-lethal methods usually are considered cutting is non-lethal, especially most people cut this way. If you cut this way and you slice your vein open, that's more lethal, but most people cut this way, and that's not considered lethal, and overdosing is considered not lethal too. All right, discussion question. You're worried about a close friend who recently broke up with a boyfriend. She's taking the breakup very hard, seems depressed. What are some questions you could ask to assess for suicidal ideation? Do you feel suicidal? And then the next question would be, do you have a plan? Yep, those two things are extremely important to ask. So again, self-assessment, health professionals might feel afraid, grief, anger, puzzlement. They might condemn that person again, think they're selfish. So we really have to acknowledge our feelings and work with them to be therapeutic. Some nursing diagnoses: risk for suicide, self-care deficit, sleep pattern, altered nutrition, anxiety, so all those types of symptoms that come along with depression. So we want the outcome is that we want them to not commit suicide and not engage in acts of self-harm. So we're trying to prevent the suicide behavior, so education, supports, resources. Treatment, we treat the actual suicidal crisis, usually in the hospital. And post-vention is an important aspect for the survivors. Because if you're a survivor, so in other words, you have a close family member, especially, or close friend that committed suicide, that puts you at high risk also. Okay? Because sometimes people just want to be with that person. So having a post-vention and actually intervene with the circle of survivors can be very helpful to reduce that traumatic effects, and also to help them to grieve and not to commit suicide themselves. So medications, therapy, safety, and teamwork, especially on the unit. We all have to work together and be aware of people that are suicidal. Now, this is kind of from the book, but we don't use plastic utensils on 1K. They actually use metal. But there are certain people that they had on the unit this past week that there was a big note saying that they could not even have metal at all. So they usually count the metal utensils, but there are certain people that they won't even let them have that. And they do not use plastic because people break them and cut themselves with that.
Well, I remember in rooms they didn't even give them any utensils if they wanted to eat in the room. They had
the scoops, the styrofoam scoop. Yes. Right, so they can't even have a spoon in their room, a plastic spoon. We don't do no private rooms. I mean, everybody has a private room pretty much. We don't keep the door open at all times, but they do 15-minute checks. And if you stagger the checks a little bit, that's better, because otherwise they're looking at their watch and they know they're being checked every 15 minutes. And a lot can happen in 15 minutes, right? They have actually jump-proof and hang-proof the bathrooms. There's been a lot of construction going on. Locking the doors to non-patient areas so everything is locked. So you guys have keys in clinical. Monitoring for and removing potentially harmful gifts. And you think, what the heck is that? But remember the guy, did I tell you about the person that they found a syringe and a tourniquet in their room? So you never know what you're going to find. Assessing belongings, ensuring that patients don't bring or leave harmful objects. Gina, again, is hospitalized for suicidal ideation after 2 suicide attempts. For the first 2 days, the patient eats 20% of their meals and stays in their room in between groups. By the 4th day, she's more social, eating meals, and has a bright affect. So what would we worry about? So she's showing improvement. The patient may have decided to commit suicide. The patient's feeling rested, supported by the milieu, or the patient is benefiting from the antidepressant she's been taking for 4 days. So what do you think? She has a sudden change in her behavior. Yes, it would absolutely be B. The patient may have decided to commit suicide because she has been struggling, and then when the person is struggling with that decision, they look pensive, they look upset, they're wringing their hands, they're anxious. But when they've made that decision, all of a sudden they can look really good. But 4 days on an antidepressant is not enough to have that significant of an improvement. So we do have to assess for suicidal ideation. All right, so non-suicide self-injury, again, is cutting, self-harm, and it is very prevalent in all areas of the world and in all age groups. So don't just think about it as young teenage girls, I think, or young adult women seem to be the most prevalent group, but it certainly extends beyond that. So we have to be empathetic, but we do have to look for triggers. Like you said, Sandeep, that your patient she reaches her limit. So her limit of stress or anxiety, bad feelings, and then she cuts to get that relief. So what is it that is triggering that type of emotional response? And we, again, have to look at ourselves, because we might feel frustrated, angry with them, not understanding that at all. So usually diagnosis is self-directed harm, risk for self-directed harm, and we want to have them experience coping, social support, self-esteem. And we are going to be limit setting. We wanted to help them develop their self-esteem, self-control, and get some replacement coping skills. You can't take a coping skill away unless you replace it with something else. So interventions, we do want to care for the injuries, but we do want to be very matter-of-fact. We don't want to give them a lot of attention, or especially negative attention. We don't want to be like, oh, you cut again, or, we don't want to show any kind of emotion. It's just very matter-of-fact, treat the injury, and, of course, treatment of their underlying disorder. So a person with which psychiatric problem is most likely to complete suicide? Personality disorder, major depression, substance abuse, or schizophrenia. It's kind of a hard question because, honestly, all of those are likely, but which is the most likely? Major depression would be most likely, but the others certainly put people at risk. And which method of suicide has the highest lethality? Ingesting pills, cutting wrists, natural gas, or self-inflicted? Yes, D would be the most lethal. All right, well, it's 10 o'clock, and I think what I'm going to do is I have a recording of the personality disorder learning plan, and that is actually very brief, so I'll just put that out there for you. And I will also put out a blueprint for the exam so that you guys can focus your studying a little bit. So have a nice weekend, and Katie, I'll see you later for clinical orientation.